Good afternoon and welcome to the Long COVID and Post-Infectious Syndrome ECHO series, a collaborative effort between the University of Utah and Bateman Horne Center. If you're joining us for the first time, we're happy to have you here. And if you're returning, welcome back. I'm Talia Rascuni, the Education and Deputy Executive Director at the Bateman Horne Center, and I'm joined by Sarah Day, ECHO Manager at the University of Utah. Before we begin, a few quick housekeeping items. Today's session is being recorded. However, all participant details and sensitive case discussions will be removed before sharing the recording on our websites and YouTube channels. After the session, Sarah will email CME instructions and a copy of the slide deck. Please note that CME credit must be claimed by midnight tonight via the call-in option, and it may take up to 24 hours to appear on your CME profile. We invite you to introduce yourself in the chat and engage as you feel comfortable. This will be our last session before the summer break, so be sure to check out our new clinical care guide and register for the upcoming University of Utah conference that we mentioned last time. I will put both of those links in the chat here shortly. This series will pick back up in October, so we hope you have a wonderful and safe summer and stay connected to some of our resources. Today's topic covers clinical considerations for hypermobile patients with long COVID and ME/CFS. Doctors Brayden Yellman and Clayton Powers will be sharing a multidisciplinary approach to care, offering insights from the provider and physical therapy perspective. Okay, let's go ahead and get started. Dr. Yellman, the floor is yours.
Today, we're going to talk about some considerations for our patients who have hypermobility connective tissue disorders, what we sometimes call hypermobile Ehlers-Danlos Syndrome or joint hypermobility syndrome or hypermobile spectrum disorder. There have been, arguments about slight differentiations between those definitions, but we're essentially encompassing all patients coming with connective tissue disease, particularly those with a polygenic presentation, ones that don't just have a single gene like the COL3A1 for vascular EDS. And when you start looking at your long COVID patients, your ME/CFS patients, your patients with other infection-associated chronic conditions, if you look close enough, you will find hypermobile spectrum disorders. Some of those are easily diagnosable via the Bateman scores. Other times, the hypermobility is found elsewhere, or you find evidence of connective tissue integrity issues in places you might not expect. But the presentations and symptoms people can experience, not unlike those in ME/CFS, not unlike those in long COVID, can of course be myriad and span all aspects of a complete review of systems. So when they come into your office and have a full review of systems, where do you start, right? Just like with ME/CFS and long COVID. So some particular comorbidities and considerations to think about when you have a patient with hypermobility or hypermobile spectrum disorder are involved but are not limited to some of the following. And these are a few I'm going to touch on today from the medical clinical provider's perspective, but there's a lot obviously to consider in working with a multidisciplinary team to really help people with the biomechanical issues that they face as it relates to these connective tissue disorders as well. So we will think about patients with ME/CFS and long COVID ME/CFS, POTS or other orthostatic intolerance or dysautonomia symptoms, mast cell activation, fibromyalgia or chronic pain, which is often related to small fiber polyneuropathy, gastrointestinal dysmotility, which I would differentiate specifically from gastroparesis, central nervous system complications, vascular abdominal pathologies, headaches, neck pain, migraine, even things like neurodivergent disorders, sleep apnea, and gynecological complications. If you see someone that has many of these comorbidities and you haven't made a diagnosis of hypermobile spectrum disorder, certainly look for them as well, because this is a two-way street. So hypermobile Ehlers-Danlos syndrome in long COVID and ME/CFS is quite prevalent. Self-reported data in a cross-sectional study of those with ME/CFS suggests that 15.5% of those with ME/CFS have joint hypermobility, and that's just those who recognize it, while 28% of those with long COVID ME/CFS report generalized joint hypermobility. And in a self-reporting prospective observational study, individuals with generalized joint hypermobility were approximately 30% more likely to experience long-lasting symptoms after recovery from acute infection by SARS-CoV-2, and many of those patients then did go on to develop criteria or meet criteria for ME/CFS. Patients with hypermobile spectrum disorders are also at a higher risk of having higher levels of self-reported fatigue when they develop long COVID, as measured by the Chalder Fatigue Scale. Mast cell activation syndrome, which we've touched on before in many different lectures and which we're not going to go into too deeply today, is highly connected to hypermobile Ehlers-Danlos as well as to POTS. So nearly 1 in 3 patients with mast cell activation had a comorbid diagnosis of hEDS in a sample of almost 38,000 patients diagnosed with either disorder. And in another study, 66% of patients with POTS and EDS also met criteria for MCAS. So certainly think about hypermobility when you have dysautonomia and MCAS present. MCAS specifically in hypermobile Ehlers-Danlos, there are irregular, recurrent, or chronic release of mast cell-mediated cytokines during mast cell activation syndrome, which include pro-inflammatory molecules, growth factors, proteases, that have been linked specifically to hypermobile spectrum disorders and other heritable connective tissue diseases. Remember, mast cells perform activity in connective tissues, and they can cause microenvironmental changes in the extracellular matrix, including IgE-mediated autoreactivity. Mast cell inflammatory changes have been implicated in contributing to the laxity of blood vessels with pooling of blood in the extremities that you see in things like POTS and dysautonomia. And in families with heritable mutations in genes encoding elevated tryptase levels, one of the major cytokines that's released from mast cell activation, 28% of these patients were found to have joint hypermobility, which is nearly double that of the general population. There's actually one literature review out there that actually found a lack of evidence suggesting that MCAS or hEDS are even distinct clinical entities because there's such a significantly overlapping pool and crossover of symptoms there. So we are still learning about whether these heritable connective tissue disorders have MCAS as a consistent feature in all of them, whether MCAS makes them worse or is present in all of them. There's a huge overlap there that we still have quite a bit to learn about, but always look for MCAS in these connective tissue disorders. This is just to say that the rabbit hole can get even deeper. Those with EDS who have comorbid mast cell can have many other downstream medical complications that are generally thought to be mast cell mediated, but almost always involve hypermobile spectrum disorders as well. And those again can include POTS, ME/CFS, post-Lyme syndrome, fibromyalgia, chronic migraines, multiple chemical sensitivities, irritable bowel syndrome, or functional GI disorders that we refer to as irritable bowel syndrome, PTSD, prostatitis, interstitial cystitis, endometriosis, vulvodynia, craniocervical instability, atlantoaxial instability, occult tethered cord, and the list goes on and on. What about fibromyalgia in our patients with hypermobility? There is a systematic review of 11 studies that showed a prevalence of a concomitant diagnosis of hypermobile spectrum disorder and fibromyalgia being anywhere from 66 to 89%. A systematic review and meta-analysis also demonstrated a pooled prevalence of small fiber neuropathy of 49% in those who had a fibromyalgia diagnosis and hEDS. That small fiber polyneuropathy was diagnosed by skin biopsy with a prevalence of 45% and had a prevalence of 59% when it was diagnosed by corneal confocal microscopy. More about small fiber neuropathy or polyneuropathy. So there have been studies looking at different ways to make this diagnosis. Again, there's quantitative sensory testing, and this was performed on 79 individuals with hypermobile spectrum disorder with amnestic complaints. And they found that 70% met criteria using this quantitative sensory testing for small fiber polyneuropathy. When they used a skin biopsy to look at intraepidermal nerve fiber density, which is the gold standard for diagnosis of small fiber polyneuropathy, these same patients showed that 78% met criteria for small fiber polyneuropathy. In this particular heat map here, you can see the distribution of amnestic complaints in patients with generalized hypermobility. And then we go on a progression system here based on the quantitative sensory testing and the intraepidermal nerve fiber density When both criteria were met, it was considered a definite diagnosis of small fiber polyneuropathy. And when one of the two criteria was met, it was a possible diagnosis of small fiber polyneuropathy. And you can see that as you get closer to a definite diagnosis of small fiber polyneuropathy, the amnestic complaints map matches that of those with hypermobility spectrum disorder in the first place. What about the role of small fiber polyneuropathy when POTS is involved? 61% of hEDS patients in a prospective study that were found to have small fiber polyneuropathy showed 63% of those with length-dependent small fiber polyneuropathy, 32% with non-length dependent, and 89% with a reduced proximal intraepidermal nerve fiber density. 53% of those in that study with hEDS and small fiber polyneuropathy were found to meet criteria for POTS using the gold standard tilt table test. Autonomic dysfunction has been identified potentially as a result of small fiber polyneuropathy, with impaired autonomic innervation potentially resulting in loss of compensatory vasoconstriction, behavior of blood flow from arteries to veins, skipping capillaries, etc. Small fiber polyneuropathy in particular is thought to play an active role in the underlying physiology, especially of neuropathic POTS. What about gastrointestinal dysmotility in patients with hEDS? So one study evaluated 129 patients referred to a tertiary neurogastroenterology clinic, and 49% of those patients were found to meet criteria for joint hypermobility syndrome. An unknown etiology for GI symptoms was significantly more likely in those with the joint hypermobility syndrome than those without. And 12 of 17 of those patients with both characteristics were evaluated and found to have delayed gastric emptying. In another study of EDS patients at the Mayo Clinic, they noted abnormal gastric emptying in 22% of EDS patients. But what I think is particularly interesting here is that 11.8% of those patients had delayed gastric emptying, and 10.5% of those patients had accelerated gastric emptying. Furthermore, I would bring your attention to how the gastric emptying studies are done. So many are done in a supine position, but at Mayo, they'll often do those in an upright position. And I have seen patients in my clinical practice who have a positive study in one body positioning, whereas in the other body positioning, they do not. So being supine or being upright can be a major trigger or exacerbating factor for underlying gastrointestinal dysmotility. And the other point I would like to bring up is that this is dynamic and changing. It is not a fixed status, which is what you would see in a gastroparesis, right? In gastroparesis from diabetes, for example, you have damage to the nerves that innervate the stomach and contribute to its motility. But in dysautonomia and those with hEDS and dysautonomia, it's not damage to those nerves per se, it's abnormal firing and functioning. And there are all kinds of other dynamic features that contribute to whether that firing is going to be more or less active at any given time. So you can repeat these studies in patients over time and get different results and different sampling error depending on what's going on. Up to 62% of patients with hEDS suffer from, quote, irritable bowel syndrome. And of those with hEDS and POTS, patients with both diagnoses were more likely to fulfill criteria for Rome-4 functional gastrointestinal disorders across various organ domains with increased upper and lower gastrointestinal symptoms beyond an already elevated baseline in hEDS. So this is another way of saying that we think that many who are diagnosed with irritable bowel syndrome and have hEDS have clear functional GI disorders. What about abdominal vascular compression syndromes, which are much more common in connective tissue disorders? We see an increased frequency of median arcuate ligament syndrome, which is or celiac artery compression syndrome, which can be compression of the celiac nerve or celiac artery by the median arcuate ligament or by neurological dysfunction at that area that leads to postprandial abdominal pain, weight loss, abdominal bruits, and can cause pretty severe weight loss and symptoms in patients. So if they cannot eat, if someone's presenting and cannot eat and has severe pain after eating, absolutely consider MALS as a diagnosis. We also see venous compression syndromes like May-Turner's, which is an iliac vein compression. There is extrinsic venous compression of the left common iliac vein by the right iliac artery, causing left lower extremity pain, swelling of that left lower extremity, venous claudication, or venous insufficiency. Nutcracker syndrome is something we also see commonly, which is compression of the left renal vein between the aorta and the proximal superior mesenteric artery, You may see left flank pain as a symptom. You may see hematuria without other explanation. Excuse me. You may see proteinuria, often orthostatic, as well. There are also many neuroanatomical complications we've associated with ME/CFS, long COVID, and other infection-associated chronic conditions that seem to be much more likely in those with connective tissue disorders. We've touched on the possibility of craniocervical instability or atlantoaxial instability before in this series. As a reminder, that is an incompetence or hyperlaxity of the ligaments and connective tissue structures, as well as bony elements supporting the craniocervical junction or the atlantoaxial junction, so C0 to C1 or C1 to C2. And this allows for increased mechanical motion and the possible resulting deformation of the brainstem or upper spinal cord with associated dysautonomia symptoms. We also see acquired tethered cord syndrome, which is an anatomical restriction of the normal movement of the spinal cord via anchoring of the filum terminale at the base of the spinal cord. And this can cause flexion stretching of the cord and trigger symptoms of lower extremity weakness, gait changes, sensory loss, lower back pain, and/or symptoms of a neurogenic bladder. This may be found concurrently with craniocervical instability and, in fact, can exacerbate brainstem positioning and the neuroanatomical positioning of the brainstem in the context of craniocervical instability. We are also increasingly recognizing venous congestion within the cranium itself and a situation that we refer to as increased intracranial hypertension, and in some cases also hypotension. So we get venous compression and outflow tract obstruction of the veins exiting the skull, which can lead to transient and often positional increases in intracerebral pressures. This will sometimes, as that pressure builds up, lead to spontaneous CSF leaks. And that's where you get this intracranial hypotension as well. And you can have associated headaches, tinnitus, specifically pulsatile tinnitus, vision changes, brain fog, and other symptoms as related to that. There is increasing recognition that many with hEDS may have these idiopathic intracranial hypertension symptoms. 20% of people with ME/CFS and hEDS had elevated CSF pressures on one study with lumbar punctures. But 85% of those with ME/CFS and hEDS who did not have elevated CSF pressures on a lumbar puncture still noted symptomatic improvements such as diminished headache, improved fatigue, less brain fog, less pulsatile tinnitus, after a lumbar puncture and after removal of some of their cerebrospinal fluid. And that benefit would sometimes last for weeks. So that actually suggests that the definitions that we've set for, quote, elevated intracerebral pressures may not be sensitive enough to capture symptoms of increased intracranial pressure for those with connective tissue diseases. We may actually need to rethink what is considered an elevated opening pressure in those with connective tissue disease. As a reminder, obstructions in these cases can arise from abnormal venous pathology with venous stenosis or tortuosity. They can come from anatomical impingements such as Eagle syndrome or an extension of the styloid process. They can be based upon compression from instability in CCI or AAI, from spinal stenosis, from disc herniations. And actually, even venous congestion syndromes in the chest, abdomen, and pelvis may contribute to venous congestion in the head and neck as well. Really interestingly, I think in this study, people with ME/CFS or hEDS may have uncharacteristic forms that do not meet these traditional definitions that we mentioned of elevated opening pressures. They may also not have papilledema on exam. So it's, I think, important to remember, too, that these venous congestion syndromes are also dynamic, just like the gastrointestinal dysmotility issues. It's based on someone's volume status. It's based on whether someone is in an upright or a supine position, on whether they just had a spontaneous CSF leak or not that relieved that pressure. And it's also postulated that many cases of spontaneous CSF leaks and intracranial hypotension in ME/CFS arise from IIH as an underlying condition, as we stated before. So pressure builds up and you get a spontaneous CSF leak and you vacillate back and forth between high and low pressures. What about other headaches and migraines that are not related to intracranial hypotension or hypertension? In a single center retrospective study, 66% of 140 patients reported headache or neck pain, with 53% of those reporting both headache and neck pain when they had concurrent hEDS. Migraine was the most common headache type among those with headache disorders, in 83% of those responding with headache and neck pain. It is thought that perivascular mast cells, particularly in or near the dura mater, can be activated by the trigeminal signaling or by cervical or sphenopalatine ganglion stimulation, causing the release of neuropeptides like calcitonin gene-related peptide, as well as other vasoactive, pro-inflammatory, and neurosensitizing mediators that all are thought to play a significant role in migraine pathogenesis and cortical spreading depression. We see increased incidence of neurodivergence in those with hypermobile spectrum disorders. Incidence of autism spectrum disorder or attention deficit hyperactivity disorder was 39% in family members of those with hypermobile spectrum disorder and fibromyalgia, compared to a neurodivergent disorder prevalence of 2.8% in a control group with osteoarthritis. Really interestingly to me, females are disproportionately overrepresented in this with neurodivergence in this hypermobile spectrum population. And that's in contrast to the general population where males are generally overrepresented with these neurodivergent conditions in the general population. Females with both fibromyalgia and hypermobile spectrum disorder were more likely to have autism, while males were more likely to carry a diagnosis of ADHD when they also had hypermobile spectrum disorder. And there appears to be common genetic or familial etiology between neurodivergent disorders, hypermobile spectrum disorder, and fibromyalgia. Those with autism, as a reminder, are often found to have high basal sympathetic tone, lower parasympathetic activation, and low sympathetic reactivity to certain stimuli, including tests of orthostatic intolerance. So in other words, they have significant sympathetic overdrive and a lot of orthostatic intolerance, just like our patients with ME/CFS and long COVID. And those with autism also have a higher sympathetic tone during certain stages of sleep and during social interaction with peers. So another kind of sympathetic overdrive condition, much like PTSD, much like infection-associated conditions. Those with EDS are 6 times more likely to develop obstructive sleep apnea as compared to the general US population, with a prevalence of 39.4% compared to 26%. It is thought that increased tissue laxity in upper airway and nasal maxillary cartilaginous defects may lead to increased nasal airway resistance and collapse and increased pharyngeal collapsibility. We may also see features like mandibular retrognathia, high arched palate, vocal cord abnormalities, chest deformities, and scoliosis in those with hypermobile spectrum disorders that can thus contribute to an obstructive sleep apnea. They are starting to use hypoglossal nerve stimulator implantation for OSA, particularly in EDS, and are finding that it's really useful in those who fail CPAP or oral appliances, which seems to be at a higher rate than those of the general population as well. Gynecological complications are not uncommon in patients with connective tissue disorders. In a study of 386 women diagnosed with EDS, 76 reported menorrhagia, 72% reported dysmenorrhea, and 43% reported dyspareunia. There is unclear evidence of endometriosis is found at a higher prevalence in hEDS, but it does appear to have a higher prevalence in those with concurrent hEDS and mast cell activation syndrome. And I think it's also worth mentioning viscerotosis. That is the downward displacement of abdominal and pelvic organs below their natural position that occurs when patients are upright as compared to being supine. And this is beginning to be recognized in patients with hypermobile spectrum disorders a little more than it used to be. And this viscerotosis, this sinking down of abdominal and pelvic organs in upright positioning, may affect gynecological and gastrointestinal functioning as well in very complex ways that we're still learning about. So that is just a sampling of the type of conditions and comorbidities you'll see in patients with hypermobile spectrum disorders, in addition to their concurrence with ME/CFS and long COVID. But there's a lot we can do from a biomechanical basis and to involve our other multidisciplinary healthcare colleagues to help provide comprehensive care and assistance to these patients beyond just managing these medical complications as well. So definitely use your physical therapy colleagues, those in occupational therapy, speech therapy, behavioral health, pelvic floor physical therapy. Acupuncturist and massage can be really helpful in these patients, and even medical genetics. And I think that is where I will hand it over to Clayton Powers to go into a little more of these multidisciplinary ways we can help patients.
Thank you, Dr. Yellman. That was great information about comorbidities, and thank you for putting a plug in for allied health professionals. With all the complexities and comorbidities that we address, we have to be a team and have a lot of members on the team to help out. So I'm going to cover and continue to touch on multidisciplinary care and then describe how physical therapists can approach treating hypermobility spectrum disorders in the context of post-exertional malaise. So here are some of the learning objectives. As Talia mentioned, Bateman Horne Center just came out with the clinical care guide, which go ahead and share with all your medical colleagues and others because it's full of great information. One of the parts in the clinical care guide that I want to emphasize is the multidisciplinary care model. So we have to know each other's roles, what each person can offer, and how we can work together. And also not overwhelming patients with appointments. Often what happens is in some long COVID clinics where the patient will get sent to multiple different specialists, and that can sometimes be overwhelming at first, instead of focusing more on the most impactful interventions or tests first. And communication between team members is super important, and we need to speak the same language, be specific, share some of these resources with other colleagues, and give them updates when you learn more. One thing that we touched on in the clinical care guide are the roles of different rehab providers. So this can be confusing. What is the difference between occupational therapy, physical therapy, and speech therapy? And there are often some misconceptions about what we each do. So occupational therapists focus a lot on ADLs and helping the patient with their occupations or life roles and making that more accessible. Physical therapists are generally seen as more movement specialists, and there are multiple specialties within each type of physical therapy. For example, vestibular therapy that focuses more on dizziness and balance. There's also neurologic physical therapy where they focus more on stroke or traumatic brain injury, pelvic floor therapy. There's several different specialties within each of these professions. And then speech therapy, often not only do they address swallow function and speech, but also cognitive function with long COVID. So while each member of the rehab team has different roles, they can all screen for post-exertional malaise, support patients with ADLs, recommend adaptive equipment and modifications, teach activity pacing and energy conservation strategies, and educate and support caregivers and family members. And then absolutely help with assisting with disability documentation and accommodations. And at the University of Utah, we work together, the PT, speech, and OT, we work together to try to share the same messaging with patients. Some of the benefits of referring to rehab are that rehab providers, we generally have longer appointments and we see patients more often. So we are able to dive into a lot of the comorbidities and go a little deeper. And then also our approach is a little bit more of a problem-solving approach. So we will spend a lot of time helping patients figure out how to implement changes or pacing, energy conservation strategies so that they can better tolerate their ADLs. We can also help support with the disability documentation as mentioned. And then, as mentioned, we have a lot more contact more frequently and prolonged contact with patients to be able to screen for a lot of the comorbidities that Dr. Yellman spoke about. And then because of that time where we're regularly seeing patients, it may take 6 months for them to see their neurologist or their cardiologist again, but rehab providers can provide updates to the medical providers about the patient's status, how they're responding to the medications. So one of the things we included in the clinical care guide was to be specific when making referrals to rehab providers. So include those comorbid conditions or other considerations when making those referrals. So mention if they have joint hypermobility or craniocervical instability, and those details can be really helpful for us. So we did include some examples of referrals that you could copy and paste when you refer to an occupational therapist or physical therapist or speech therapist. We wanted to make it so that when you send these referrals, it can help the rehab provider have a better idea of what kind of approach you want them to take. And so what I'll show you in the referral to physical therapy, for example, do not prescribe graded exercise or activity if the patient has post-exertional malaise, and then also offer telehealth if able. Often patients are referred to physical therapy for exercise. They're told, hey, you need exercise, right? That's the prescription. And that's the traditional referral. And everyone on this call probably knows that most patients then try some exercise and it doesn't go so well. And it's not very tolerated, especially if they have post-exertional malaise, orthostatic issues, or some of the other comorbid conditions that Dr. Yellman mentioned, especially if they already are struggling with taking care of kids or doing their ADLs, taking showers or climbing stairs. If their ADLs are already super impacted by their symptoms, then it can be really hard for them to hear advice about exercise when it's already really challenging and just to do ADLs. So, and all of us know exercise significantly benefits most people's health. It's considered a wonder drug. And if you search exercise online, you get tons of pictures of people smiling, high fives, thumbs up. Even babies love it. Dogs love exercise. So exercise, we know, can be really helpful for most people. But if exercise is medicine, then dosing is really important, because often if we overdose a patient, or if the exercise isn't really meaningful to them, or that it's not progressing toward their goals, then we have to adjust some of those things. So we acknowledge that exercise can be helpful for most people, and it can be even helpful for POTS and orthostatic intolerance, but it can be harmful if it results in post-exertional malaise. And graded exercise is not recommended for patients experiencing post-exertional malaise. And post-exertional malaise can vary from individual to individual as we screen patients and talk with them. Often patients will say, yeah, it takes me about a day to recover. Well, someone else, they may say it takes me 3 to 7 days to recover from a busy day or too much activity. And so figuring out the level of activity that someone tolerates is really important up front so that we don't overdose them with activity, or we can help them better monitor their symptoms and reduce the likelihood of post-exertional malaise. And so with individuals who have hypermobility spectrum disorders, we screen for post-exertional malaise, we monitor during and the days after, and we try to base it on tolerance level. And this is really important. Exercise should not be pushed at the expense of the patient being able to tolerate ADLs. So one example is there was a patient in Utah that I heard about who was pushed by their physical therapist to do an exercise protocol for POTS that actually resulted in them becoming so fatigued that their legs became fatigued and they were walking down the stairs and they gave out and broke multiple bones in their body. So when exercise is pushed at the expense of being able to tolerate walking up and down the stairs at home or doing other activities, then it's not very therapeutic. Patients are usually referred to rehab providers. This is my observation. Usually patients come to therapy and they're referred for a symptom like joint pain, joint instability, deconditioning, any of these different symptoms, pelvic floor issues. But that's why it's so important for therapy providers, rehab providers, to screen for connective tissue disorders, hypermobility. Often when I screen for patients and find that they do have hypermobility, they say, what does that have to do with anything? And so no one's taken the time to educate them about how there's a connection between their hypermobility, connective tissue issues, and a lot of their symptoms. So super important to screen, even if I'll see this as well. Like last week, I had a patient who was referred to physical therapy for knee pain, and she was working with a therapist, and she did several visits, and finally it was like, this isn't working. You're not getting better. I don't know what to do with you. I ended up seeing the patient, and most of the therapy was so focused on her knee pain, but then when we got talking, she had a lot of other comorbid conditions from her connective tissue disorder that were more important to address first. And so as we address all those systemic symptoms, then it becomes a lot easier to address the instability and pain. Here's some screening tools. Here are some screening tools for therapists to use. One of the main things is screening for systemic signs and symptoms. So here's some questions that can be helpful when you meet a patient who may have been referred for joint pain or joint instability, but it's also important to ask a lot of other questions in that first appointment and throughout. Some of the main screening tools for hypermobility are the Bateman scale. Everybody should know that one. And then there's a lower limb assessment score and the upper limb assessment hypermobility scale. I have links to these when we share the slides, links to studies on how to do it and other information. So you know the Bateman scale. There's also the lower limb assessment score. We don't generally go through all of these on the first visit, but especially if somebody has post-exertional malaise, we try to limit how much examination or other things we're doing in the visit. But I just wanted to do an overview of some of the general screening tools for hypermobility. Here's the upper limb score. So some aspects that we use looking at the shoulder, wrist, fingers, elbows. And so this can be really helpful as well because some people are more hypermobile in their upper body than their lower body. And then some people are more hypermobile in the lower body. It varies. And then as therapists, when we're thinking through clinical reasoning of how to help patients, we have to determine if the biomechanical issues are driving the systemic symptoms or if the systemic issues are more important to address and are driving the instability and pain. So for example, with the biomechanical issues being possibly craniocervical instability, tethered cord, malls or other venous compressions, or some of the other conditions that Dr. Yellman mentioned, we have to determine if those are the priority to fix or to support and manage, or if there's a systemic issue going on that's driving their symptoms like mast cell activation or gastrointestinal or immune challenges that are more important to address before they participate in traditional physical therapy. So where do we start? It's kind of a mixture of reasoning and intuition. But the most important piece is the good subjective history taking, spending a lot of time to really understand the patient's history and symptoms without overwhelming them during that initial evaluation. So providing the questionnaires or screening tools ahead of time so that the patient has time to fill out some of that and for you to screen for post-exertional malaise prior to their first appointment. And then we do a lot of trial and pivoting. We try some things and then see how the patient responds. So for example, pneumatic compression is something I like to use. The majority of my patients who have orthostatic intolerance find that it can be really helpful and push blood back to the head and help with venous congestion in the legs and things. But it can also be diagnostic in that some patients don't tolerate it and say, oh, that increases my headache, which can be a sign of intracranial hypertension or venous compression. And so that can help us to determine how to pivot. And so we try a lot of different things in therapy visits to try to manage the symptoms and give tools to the patient to manage their own symptoms. So instead of just addressing joint pain or instability, when I get a referral of a patient and it says neck pain and instability or shoulder pain and instability, first I have to determine if the systemic issues are actually more impactful and are causing the patient more difficulty to stabilize their joints. So we'll look at whether they have post-exertional malaise or neuroimmune exhaustion or other neurologic issues that may be contributing to the poor joint control. If you're fatigued, if you're in post-exertional malaise, you're not going to have enough energy to control those joints and muscles. So we want to make sure, first of all, that we address some of those other concerns before just jumping into giving them stabilization exercises. And here's some goals for therapy. And I just want to highlight that we want to focus mostly on quality of life and ADLs more than getting somebody back to exercise. Now, if the patient, their goal is to get back to exercise, then I'll put that in there as one of the goals we want to work toward. But first and foremost, we work on ADLs and quality of life and seeing if exercise is where it fits in. So this is kind of an approach to take. We talk so much about with hypermobility spectrum disorders, we talk a lot about stabilization. And so we want to, as mentioned, identify those systemic issues and then refer when appropriate or try to address them. And then we want to stabilize not just the joints, but we want to stabilize the environment. So reducing stimulation in the clinic, reduce paperwork, possibly offer virtual appointments. We want to stabilize the emotions by listening, believing, validating, creating a plan, and educating. We want to stabilize the nervous system with autonomic quieting, position changes, and trying to lower the threat and stressors of the appointments. And then try to stabilize systemic issues, like helping with post-exertional malaise with pacing, mast cell activation with education, and orthostatic intolerance with using compression garments or electrolytes. So we stabilize all of those other things. It becomes a lot easier to then work on stabilizing joints. And this, I don't expect, we're not going to run through all of these, but in working with patients who have hypermobility spectrum disorders and other immune challenges, it can be a lot. It can be hard, and there's a lot to take into consideration. And so when referring to rehab providers, you want to know that your rehab providers or therapists, that they understand these complexities, at least that they're aware of them. There are therapy providers, for example, who may not be aware that there's a connection between hypermobility spectrum disorders and a lot of the other comorbid conditions. And so they may be sent for dizziness or headache or neck pain or pelvic floor issues. And there's other things that the therapists need to take into consideration. And so it's important to work with your rehab providers and share the clinical care guide or other resources to help them if they don't have that background. And so some of the things you want to avoid, burpees especially. I don't think most people would get burpees starting off, but I put that in because frequent position changes can be really hard, not only with hypermobility, but with the orthostatic intolerance and post-exertional malaise. We want to try to avoid overstimulating patients in the clinic and with their exercise programs or other recommendations. We want to avoid repetitive strain on the joints or positions that overstretch the joints. And then one that I've found really common is the overheating. That if we in the clinic can manage overheating by using cold packs on the stomach or the neck or different areas during the strengthening exercises, patients tolerate it so much better than if we don't pay attention to that. So often I use cold packs and other things throughout the session, and I tell patients to use cold packs when they are doing exercises at home to avoid that overheating. So generally some of the things we can offer as rehab providers or physical therapists: education, activity modifications, lifestyle changes, and exercise for the joint hypermobility issues. In the Muldowney protocol, they talk about going from belly button down first to build a foundation, since your foundation is more your feet and your pelvis, and then your spine rests on top of that. So focusing on belly button down first, stabilization exercises. And often a lot of my patients with EDS will say that cardio is really, they don't tolerate it well, and that strength and control exercises are a little bit better tolerated. So we often will start with very gentle strengthening exercises. Manual therapy can be helpful, as well as other types of support. Assistive devices. I had a patient recently tell me My mom won't let me use a wheelchair when I need it because she says, you're giving up then. And there can be barriers to using assistive devices, like a shower chair can be something where somebody doesn't want to use it because then I feel old or I feel disabled. And I just try to reframe that as this is a tool and it's going to help you be able to tolerate things better. And so there can be barriers in convincing people to start utilizing these to help them. There's a lot of myths about bracing as well. So I wanted to cover that. Rigid bracing can be helpful, especially for small joints like the fingers. The fingers and toes are kind of wimpy and they need some extra support sometimes and need that rigid bracing. Our hand therapists will tell us that hands do best if you just give them time away from being loaded or strained. During acute injury, it can be really helpful. Or if the patient has to sustain a certain position for long periods of time, like sitting, it can be okay to use rigid bracing. They can weaken your muscles if you're using them for prolonged periods of time, but that's where joint supports can come into play. So, for example, the sacral lock is an SI joint support. That is not going to weaken your muscles as much as a rigid brace. So we don't worry as much about weakening muscles and atrophy with the joint supports that just provide extra support when you're moving around and things. It's okay to recommend those, and people can wear them for longer periods than maybe the rigid braces or splints. And then taping, similarly, if you look at the tape on the left, the tape is very supportive and more, it helps to immobilize the ankle. And so that can be good during more high impact activities or more when you're having more strain on it. So we brace for activity, not for most of the life activities or ADLs, you don't need a brace for, but for if you're going for a hike or other activities that are more straining, it's okay to brace. And then tape can be really helpful as well for proprioceptive feedback. The main issues are skin fragility and then adhesive reactions. So a lot of patients with EDS will have mast cell reactivity. And so using liquid cromolyn on the skin or even the nasal form of cromolyn sodium has worked so that people don't have as much of a reaction. I've seen other things like Imodium or Pepto-Bismol or milk of magnesia. I've primarily told patients about nasal crom. It works great. And some people go to town with tape, they go a little crazy with it, but it's okay. It doesn't, as long as there's no skin reactions or skin fragility issues, it can be a really helpful tool for lymphatic drainage, for proprioceptive feedback. So as long as there's not a lot of reaction to it, it's fine to use it. And then some other ways we manage symptoms and pain with hypermobility: education, autonomic quieting, breathing, tactics to kind of down-regulate the nervous system, so stabilizing the nervous system, and then appropriate exercise, cold or other sensory modalities that can help, like TENS units or compression, topical rubs. We could go into so many of these. There's so much depth in all of this, but this is just a general overview. And then I put links to some studies about green light therapy and photobiomodulation. And then supplemental oxygen. There's a study out of France looking at, they had patients with EDS and they gave them oxygen supplementation about 20 minutes 2 to 4 times a day, and found that it was really helpful for fatigue and migraine management. And so I put that, linked that study to this page. So when we do finally, after stabilizing the environment, stabilizing emotions, reducing stressors, helping the patient not have post-exertional malaise, then we will focus on stabilizing joints. And so we'll work on cueing. Usually external feedback like hands-on or tape or other things is more helpful, because often they find that with hypermobility spectrum disorders, there's a decrease in interoception and proprioception. So providing feedback that's not just verbal, but tactile and sensory can be really helpful. And we'll start with isometrics or other holds for short periods of time to build that strength, and then bracing for activities. So that's kind of the approach. Here are several resources that are available that are really helpful. The EDS New Zealand course has multiple videos and resources. It's really helpful. Downey protocol. A lot of these resources just have so much abundance of information for individuals with hypermobility. And then we also have the Bateman Horne Center resources for post-exertional malaise, orthostatic intolerance, and pacing. So check those out as well. So it's a lot, but rehab providers can make a huge difference with managing these symptoms. Thank you.
Thank you, Dr. Yellman and Dr. Powers. That was great. I really appreciate seeing the clinical side, right? And then the applied side through the allied professional. And I think that we all have seen in working together so much that it really improves the patient outcomes because we're taking that whole person approach. What questions do we have? I've seen a couple in the chat. Most of them have been answered by now. There was one in here. I'm going to read it to you, Clayton. I'd like to know more about your exercise prescription with your patients with hypermobile syndromes and PEM. I think we talked about that. If there's anything else that you want to add.
Yeah, usually I start by reframing like the goal of therapy. I want to give the person the tools to manage all the symptoms first. So I usually, the first visit, if the person has post-exertional malaise, it's a lot of education in providing those tools. And then once the person has better management of their symptoms, then we'll usually focus on the pelvis and core. So doing isometric exercises with tactile feedback to engage those areas. One of the things that I see a lot is we have to keep in mind is the shearing forces of certain exercises. So you put them in the position that they need to hold, like posture in a neutral spine or neutral positioning, and then try to hold those positions. And then we'll take rest breaks versus trying to put a lot of shearing or adding weights first. I'll usually do recumbent exercises like bridges, or it's hard to give a lot of examples because there's so many different exercises that we may go to, but usually they will start with isometrics, meaning just holds to activate the muscles around the joints.
I'd like to touch on that too, just from a provider's perspective. You know, we've talked about exercise and PEM plenty of times in this forum before, but I think it's important to point out that, you know, there's a lot of studies that show exercise is really helpful for orthostatic intolerance in POTS, and I think that's unmistakable. Those studies are not well done in so much as determining who has any CFS and PEM, but it actually, exercise helps everybody if you can do it without triggering post-exertional malaise. And so for me, the natural order of operations that I've seen, as much as we want to start with something non-pharmacological, exercise, it's great, it has no side effects, right? That's just not true for PEM. On the other hand, I've treated patients for maybe 2.5 years. We've done a lot to support orthostatic intolerance. We've done a lot to improve their energy envelope and improve pacing. They're getting better at recognizing their triggers for PEM and using heart rate monitoring or heart rate variability and knowing what their body feels like as they're approaching, you know, starting to get worn out, or how to take breaks from that before they return to activity or exercise. We've supported sympathetic dampening measures. We've supported mast cell treatment. When you've done all of those things, you've created a much more stable situation for a patient. Sometimes we even support their metabolic capacities, right, with things like sirolimus or methylene blue or oxaloacetate. When you get to that point and they can avoid post-exertional malaise consistently and they're functioning better, that's when I think about the phase of exercise. That's when I really say, you know what, it's time to start weaning some of this polypharmacy that none of us like to have to do, but we have to do to help these people. It's time to start using exercise to help us start weaning those things. And in particular, I've seen people be successful in that environment, in that supported environment, adding back in exercise, avoiding post-exertional malaise, and gaining the benefits of exercise. And then we wean them off of especially some of their orthostatic support. But that's the order of operations that's worked for me. You really have to give them all chances in the world to avoid post-exertional malaise with exercise. And if they were a former athlete, you really have to train them that exercise is done differently now. It is not push yourself for gains. It is really disciplined, slow, give yourself extra time for recovery type of exercise, as we've talked about before.
Absolutely. That is, yeah, I just had a patient earlier who hasn't had post-exertional malaise for several months and is feeling more stable and brought up, I want to do some more exercise. So often we'll start with things that are short and slow and have plenty of rest breaks and monitoring temperature and other things. And it can be beneficial at that stage once things are a little bit more stable.
Well, and it's really hard when you're talking to patients who are, I mean, all of them are likely some sort of type A. I mean, any of them, right? They don't want to lose pieces of their life, and trying to reframe that exercise is just an exertion, right? And so ADLs and being able to perform your daily life activities come first before any of that. And that's a really hard reframing. And then we're able to have, deeper conversations as you two just presented here.
I wanted to bring up a really interesting case that I actually just saw this morning, by the way, that I think is related to these topics. So I have a patient, a middle-aged woman with pretty severe mast cell POTS. We've done a lot to try to control those things, but has a lot of symptoms. She's got left flank pain. She's got left lower extremity swelling and pain. She gets pain when she lifts her left arm above her head and swelling in the left arm. She also gets pressure headaches with tinnitus and visual changes and brain fog. And so we're concerned that she may have intracranial hypotension. She may have thoracic outlet syndrome. She may have May-Turner's. She may have nutcrackers. She may have all of it. And, where do we start? What do we do in this patient? And I want to mention that she is seeing a physical therapist. And when she goes in and gets mechanical adjustments for the fact that her hips pop out of place and her ribs pop out of place, she feels significant improvement in pain and functional status for a few days after that. When she gets, realigned or biomechanically adjusted into a better position. And one of the questions we were asking today is, okay, that provides functional benefit, that provides pain benefit, but does that relieve the left lower extremity swelling? Does that relieve the left upper extremity swelling? Does it relieve the flank pain? And for her, it didn't, right? But for other patients, it does. Actually getting in the right biomechanical position may relieve things like a venous congestion syndrome, but sometimes it doesn't. And so, in fact, not only were we helping this patient on a biomechanical basis by using physical therapy, but I was actually getting diagnostic information from the help of the physical therapist that even when we've done things to fix the biomechanics, that the venous congestion is still present and may need to be addressed from another perspective, not conservatively just with getting into a better biomechanical place through physical therapy, but actually through some other type of procedural intervention. So you can also use multidisciplinary care for diagnostic purposes to help get more information about when we fix X or change Y variable. Does that help us better understand how to prioritize what to do in this patient next, or if this is, driven by A or B in a complex system like this?
I appreciate you bringing this full circle. Always love when there's a patient case to talk about. We are at time. I hope that you have enjoyed the first part of our Echo series this year. We kind of wanted to go back to the basics and then start weaving in some of these clinical considerations throughout the rest of our series. So, as a reminder, we will pick back up in October. So, this fall, we will be talking about pediatric and young adults, navigating sleep challenges, and neuroinflammation's role in long COVID and ME/CFS. If you haven't checked out already, please do. In the chat box, I've listed a couple of announcements, the release of a clinical care guide. We have some self-paced patient modules to help individuals learn a little bit more about their experience with OI and PEM. And then, of course, the University of Utah's CME event. At that last little bullet point there, that's how you sign up, emailing Amanda Brown. And that will be taking place in September the 25th. So we'll leave that up for just a few minutes if you want to copy and paste that. Until this fall, please take good care of yourselves. Thank you.